It's 9 o'clock. Ms. Jamke, am I right?
Yes, Chair. You can start.
Thank you so much. And I believe we do correct in order for us to proceed.
Yes, Chair.
Thank you very much. I wish to welcome all members present, all officials and all guests. And thank you so much to our support staff present as well. Colleagues, I'm sure that you won't mind as us preserving a moment of silence for our healthcare workers on the front line and in the cold face of this pandemic, and also to those that have succumbed during this period. Can we please preserve a moment of silence? Thank you very much. On the rules of our online engagement, colleagues, I would ask you to please mute your microphones as well as to switch off your cameras in order to limit any interference or to have any connection problems. You will also see on the right-hand side of your screen, there is a chat function that will be used for points of order. And should you be unable to access the raise your hand image on the bar, you are welcome to do so in the chat function. Can I please ask that we do not use this function for random conversations, please? So yes, while you are more than welcome, members, whilst posing a question or raising your point of order, to switch on your mic as well as your video and turning it off immediately after. I would now request members to please introduce themselves. After members, the department representatives may do so.
Good morning, Chairperson.
Good morning, Chairperson Regan Allen.
Good morning, Chairperson Ayanda Barnes.
I guess that is all the members, the department representatives.
Morning, Chairperson Stacey from Minister Nama French Mbomba's office. Good morning.
Morning.
Morning, Madam Chair. It's Dr. Krish Vallabhji from the Department of Health.
Good morning. It's Leslie Shand from the Department of Health.
Anyone else from the department? Not. Thank you very much. And also to Ms. Namonde Jamke, thank you so much for your presence and your assistance as well. We have received apologies from Dr. Nama French Mbombo, the Minister of Health, as well as Dr. Keith Kluter, who is engaged in Cabinet Interministerial Infrastructure Committee at the moment and will not be able to join us. Colleagues, the purpose of our meeting, we will be dealing with, or will be briefed by the Department of Health on TB-related cases and on the levels of children's vaccinations in the province. I will now then ask immediately for the department to present to us. I believe that all members have received the presentation and you have aligned your questions accordingly. So we will deal with both presentations, which is on one document. And if the department can please share that document with us on screen, after which both has been done, we will then deal with the questions and answers accordingly. So the department representative dealing with the presentation may please proceed. Thank you.
Thank you, Madam Chair. So just by way of introduction, thank you very much for asking us to talk to two matters. The first one is TB and the second one is immunization services. So just just to introduce this, as you know, in the last about 10 weeks or so, the department has been heavily preoccupied with trying to create capacity for create capacity for COVID, and we.
Excuse me, just one moment, Dr. Vallabhji.
Thank you.
Ms. Jamke, can we please make sure that all members are muted from our side? You might proceed.
Okay.
Thank you.
So over the last 10 to 12 weeks, we've been quite preoccupied with trying to prepare for the huge kind of service pressure and surge that's going to be coming at us for COVID patients. And so there has been, as part of that preparation, there has been an intentional de-escalation of services in the department at all levels, from primary health care right up to hospital levels, critical care, to try and create that capacity. Over and above that, I'm getting some echoes, Madam Chair. So over and above de-escalating, we've also created a lot of additional capacity. There's negotiations with the private sector, etc. And so that's a topic for another day, but it's an important context for what we're going to be discussing, because in this process of de-escalating services, the question of what is happening to non-COVID services becomes an important one. The top management just recently recognized the importance of this and has asked for a kind of deep dive preparatory session towards the end of June to start taking stock of what's happening to non-COVID services. So the technical colleagues are busy working on that. Last week, Friday, there was a conversation with the Metro colleagues to look at this. And clearly the early signals for April is starting to show significant drop-offs in terms of services for non-COVID patients. And clearly, if one doesn't attend to that, one could end up with adverse outcomes. So it is an important matter. So for the purposes of this morning's conversation, we've chosen the two that you have requested, TB and immunization. And Ms. Leslie Shan will go through the presentation, and you will see the patterns for the month of April. But the department has already started to put plans in place to remedy and recalibrate our services to address this challenge. But I'll hand over to Leslie Shan. Thanks.
Thank you, Dr. Vallabhji. Ms. Shan, you may proceed. Thank you.
Thank you, and good morning again. So as Dr. Vallabhji said, we're going to be talking about TB and immunizations. So just as a preamble, the department has employed some strategies, not only the department, but the government itself. And so we had the lockdown since March. Schools and creches have been closed. Public transport and taxis were limited. There was a lot of communication to the public regarding staying at home, sanitizing and social distancing. We de-escalated a lot of our health services. One in particular was elective surgery was limited to the minimum, and we've prioritized COVID-19 within the department. We've also involved our community health workers in other activities like COVID-19 screening and testing at homes and in businesses. And we've implemented some measures to ensure medication reaches those people who are on chronic medications. And so we've put in place repeat meds so that they don't have to visit the facilities too often. So all of these things have had some impact in some way or other on the service and patient attendance. So the outcome of this is that in some instances, the public are actually fearful to visit our facilities. They can't necessarily get to our facilities because of lack of transport at the right times. There is quite a bit of queuing happening outside the facilities, mainly to maintain social distancing, which is not always convenient. Then if we look at the performance of the department, of the services, the headcounts at our primary healthcare facilities, if I compare from April this year to April last year, there was a 56% drop in over 5-year-olds who visited the PHC facilities and a 70% drop in under 5-year-olds. At our hospitals, we had a 50% reduction in outpatients, 44% reduction in emergency cases, and 24% reduction in inpatient days of our inpatients. The effect of limiting our elective surgery resulted in a 56% reduction in operations, and in some instances where we've had positive healthcare workers, we've had to close facilities temporarily while we sanitize them, shifting patients to other facilities. Now, if we look at immunizations in particular, our situation last year was that 85% of the children in the Western Cape are fully immunized at under 1 year. In the metro, which contributes 65% of all of our children, 86% of them were fully immunized. But we expect this number to decrease unless interventions are put in place to catch up any missed immunizations. So when I compare what happened in April, April's the most recent data that we have. May's data is still coming. But if we look at April 20 to April 19, and then the annual average for last year, you can see that there was a drop-off in the fully immunized under 1 year. And similarly, in all of our immunizations, an even bigger drop-off between the April last year and this year. The districts which have been mostly affected are the metro, obviously our biggest contributor, and then Overberg and West Coast, which all actually are hotspot areas, so it makes sense. Just looking at it from a different perspective, month on month, our fully immunized over the last year and up to April this year, for the province as a whole, you can see that we were running at about 14 to 16,000 immunizations a month, and that dropped down to just under 8,000 for April. This is metro, has a similar pattern, and then a slightly smaller drop in the rural districts. If we look then at the various immunizations that take place, what I've done here is just split the services into immunizations taking place in private facilities. We have some private facilities contracted to do work for us, so private pharmacies, etc. And I've just compared them again, annual versus April versus April 20. and then the public sector. So you can see in the private sector, let's take measles first dose, for instance, there wasn't much of a drop-off in the private sector. Again, in the second dose, in PCV, third dose, and retroviral rotavirus has dropped slightly. So overall, we're seeing about a 8 to 10% drop in private facilities in the immunizations. However, in the public sector, you can see quite a drop-off in most of our immunizations, and that's about a 34, 36% drop-off from last year, April. BCG doesn't have such a big drop-off because BCG takes place in hospital when the baby is born, so most of that is still taking place. And then fully immunized would still be affected by immunizations that took place during the year. So it's not having as big an impact there yet, but we expect to see that over the next couple of months drop. So what are we doing, or what have we done, and what will we be doing to remediate the drop-off in immunizations? Our strategy is to support services to deliver adaptive and responsive immunization services whilst maintaining safety for the health worker and the children. At all our facilities, vaccination is free of charge, and these services continue during the pandemic and lockdown. We've got mobile services which also continue. And then in some areas, we've implemented staggered appointments so that we can maintain social distancing, particularly in small clinics where we don't have space. Immunization and child growth monitoring services are continuing, and where possible, we opportunistically try to catch children who haven't been immunized and check their growth as well. Obviously, keeping physical distancing as a priority. Each facility looks at the births that they've had in their area, and then they recall or notify children who are under 12 months who are in need of catch-up. So they go through their birth registers and check that patients have been immunized. Hospitals, any children admitted to hospitals, one of the things that they do there is now also check for the Road to Health booklet to make sure that the child has been immunized, and if they haven't, they will immunize at the hospital. Community health workers have also been involved to recall children who have missed immunization, so they actually go to the homes and check the Road to Health booklet and then refer them to the clinic to be immunized. They're also doing that when they would do COVID-19 household screening. They're checking Road to Health booklets while they're at the house. So just opportunistically doing that while they are there. Then, as I said, we have contractor private providers who continue to provide services. And this has actually helped to maintain some of the immunizations. We found that anecdotally, patients prefer this in some instances because they're shortening waiting periods. And then they're also fearful of contracting COVID-19 in our public health facilities. In some instances, it's easier to get to private providers because of difficulties of transport. And then, of course, it's easier, perhaps in some instances, to have social distancing in private sector. The Road to Health booklet screening is also done when we admit children to our quarantine and isolation facilities, and then also at homeless shelters we're checking. In terms of our communication strategy, the department continues to strongly advise mothers to protect their children from infectious diseases by getting them vaccinated from birth to when they're 12 years old. We're using different types of media to effectively communicate this, things like the local radio talks, newspapers, social media groups, pamphlets and posters, and then opportunistic education during our community screening and testing program as well. We're focusing our messaging particularly on mothers and caregivers of children, and preventative messaging is also going out in our hotspot areas to try to maintain immunization rates. Our vaccine suppliers, we continuously monitor that. We haven't had any vaccine stockouts during April, but we continue to monitor that. And then overall, we monitor the targets that we've set for each facility and sub-district each month to check how close we are to the target that we set, and where we're falling short of the target, we put particular emphasis in implementing remedial actions in those areas. And then, of course, we continue to monitor any disease outbreaks as we would normally do. In terms of people management, there's management of staff shortages due to COVID-19 infections. We're supplying and stock and upskilling and refreshing our professional nurses with community health workers to immunize COVID-19 positive children outside of facilities. And then there's a clear catch-up plan will be developed for those who are unable to access routine immunization during the lockdown period. So that's in terms of immunization. If we can move on to TB. So just as an overview, the Western Cape has adopted the National Strategic Plan on HIV, STIs and TB for 2017 to 2022. And the aim is to ensure early diagnosis, successful treatment of TB patients, and strengthening of partnerships between local and provincial health authorities and citizens to eliminate the threat of TB in the Western Cape by working better together. Current overview of the status of TB in the province for 18-19, which is when the outcomes are available for that cohort of patients. We screen about 51% of the patients who attend our primary healthcare facilities, and 3% of these patients test positive. On average, 99% of the sputums that are sent to labs for patients are sent to labs for patients who are screened positive, and 89% of those diagnosed with TB are started on treatment. Our success rate at the moment for drug-sensitive TB is 78%, and for drug-resistant TB is 67%. We have a 9% of patients who are lost to follow-up. So the impact of COVID-19 has been that opportunistic screening and testing is reduced because less people are actually in our facilities. People have missed appointments due to the lockdown, lack of transport, social distancing, and stay-at-home messaging. Although we've provided repeat meds to patients so that they don't have to visit the facility, there's obviously less supervision and monitoring of the patients due to this, which impacts on their outcomes. And then when we had a look at the people that are attending our facilities, we've noted that of those that visit the PHC facility, we're actually screening a higher percentage than we were last year in April. Last year we screened 54% of our patients visiting the facility, and now we're screening 81%. And this is mainly due to the fact that most of the pharmacy attendances are being done outside of facilities now. If we look at the number of TB-related visits to our facilities, you can see that there's been a overall decrease in April, and even in March it started. So there are less attendances due to TB at our facilities. Screening. Just to show you briefly there, in April you can see quite a big drop-off. Previously we were screening around 700,000 a month, and now we're down to 400,000. On those that have started on treatment, previously we were sitting at about 2,000, just over 2,000, and we've dropped down to 1,000. So the remedial actions that we've put in place for now are all stable TB patients receive their medication at home via our community health workers to avoid coming to the facility, or they're able to get it from quick pickup points outside of the facility. Only those that are at risk of acute decompensation or exacerbation continue to be seen at primary healthcare facilities. And then it should also be noted that there's an overlap in the symptoms of COVID-19 and TB, and we remind our staff to be on the lookout for TB in all patients as well. Patients needing investigation for TB are assisted at our facilities as usual, and where possible, newly treated patients with either drug-sensitive or drug-resistant TB are followed up at home by community health workers. Case finding for patients with TB continues amongst patients attending the facility, but obviously because we have less patients there, we are less able to find new patients, new TB cases. And then community health workers continue to refer symptomatic people for TB investigations to the primary healthcare facilities. In general, for the department, not specifically for TB and immunizations, we've maintained our start and close times for all of our facilities, except where we've had to close facilities temporarily for desanitation. We've put in place home deliveries or pickup points for medication. In the metro, one of the examples we have now is Uber deliveries of medication. Community health workers have had to increase their services, so we are busy appointing more community health workers, and we've asked the community health workers where possible to manage patients outside of facilities rather than referring them to facilities. And then later this month, as Dr. Valoji indicated, we have scheduled a deep dive for the department to actually review and consider the gaps in our service and treatment, and see how we can address and remediate that. Thank you very much.
Thanks, Leslie. So Madam Chair, if I can just introduce Mr. James Krueger. He's the Acting Chief Director of Health Programs, who's also joined us on the program. Yeah, so I think the main messages from what Ms. Shan has presented is that there's definitely been a drop-off in services. As far as TB goes, I think the concern is not so much those patients that are already on treatment, because they are receiving their meds, and if one assumes they are taking that, that's less of a challenge. The main challenge is being screening, diagnosing, and starting on treatment of new patients. So case finding is where the big challenge is. But that's the situation as far as TB and immunization. So thank you very much.
Thank you very much, Dr. Valoji, as well as Ms. Shant, for that very brief presentation on services delivered, on the impacts, and as well as pointing out to us the remedial action as to which the department has embarked on. Members, I will now open for questions. If you can please raise your hands accordingly. Please proceed, member. Honorable Botha, you may proceed.
Okay, Chair, sorry, I wasn't sure whether it's Botha or Barnes to proceed. I just wanted to check, Chair, does our strategy or the department's strategy for the metro as well as the rural remain the same? And I must congratulate the department in terms of the delivery of meds now to our TB patients. I think that is something new and added to the department, so well done on that. But just speak to, in terms of your communication strategy, in terms of TB cases, the communication to those patients, in terms of the importance of not defaulting in regard to the pandemic that we are sitting with now. Thank you, Chair.
Thank you very much, Member Botha. Member Barnes, you may proceed.
Thank you, Chairperson. Chairperson, I think I only have 2 questions that I need clarity on from the presentation, especially on the TB one. I think on the last part, the latter, there was a statement made that said the only challenge is on case finding. I would just like to have a better understanding what is meant by case finding. Maybe it's a medical term, but I was a bit lost on the case finding part. And the second one is on slide 18, the impact of COVID-19 on TB. What could be making the stats to be dropping? Because the slide was indicating that the TB stats are dropping. What would be the reason for that? If also I could get an understanding as a normal civilian, I think that is more medical report for me. It's the only 2 clarities that I would like to have. I thank you, Chair.
Thank you very much, members. Any other member? Not? I wish to pose the following questions to the department. You made mention of, on average, 89% of diagnosed TB patients start their treatment. What are the main contributing factors for that percentage, or for that count of people starting such? And then also on the success rate of TB cases also. And then we now see that the winter season is setting in. We have a drop in temperatures, of course, which is also conducive to the spread of COVID-19 and seasonal flus, and of course causes co-infections as well. We also see that in the lower socioeconomic groups within our society, where especially social distancing is a challenge, what is the implications thereof, and what is the department's overall projections, and what will the remedial action be that will follow accordingly? And then also, yes, I think the department really gave us a very thorough indication this morning. And we, of course, welcome as well the appointment of more community healthcare workers, because it seems that they are really playing a very integral and important role within our communities. The matter on immunization, what is the remedial measures on how successful has it been to track those missed cases, and what is the department's outreach strategy in the remote and the most rural areas within this province? I conclude with that. Members, I will now allow the department to answer these questions, and you are most welcome to pose your follow-up questions should you have any. Member Botha, do I see your hand?
Yes, Chair, thank you for recognizing me. I just want to ask as well, in terms of case finding for TB, the shelters that was created for the homeless during the lockdown period, was that those shelters at all considered to, for case finding with regards to TB?
Thank you very much, Member Botha. The department?
Thanks, Madam Chair. So I will start, and then Mr. James Krueger and Ms. Shan can come in. So the strategies between rural and metro, they're very much the same in principle. I think rural, just because of the distances, etc., the mobile service plays an important factor in the rural as well. But other than that, I think the issue of community health workers and outreach and all of that is the same. In terms of communication to patients about not defaulting, I think, Madam Chair, as you've alluded, the community health workers and their household visits are a key plank in our strategy, because that face-to-face contact and that opportunity to create awareness, to emphasize adherence to treatment, etc., is becomes a very, very important thing, and that is why we have employed more community health workers now because of COVID. But as part of our remedial strategies going forward, the intention is that we use the community health worker visit to the household not only just for screening and testing for COVID, but we use that visit to talk about all of these things, whether it's TB, whether it's immunization, etc. So that's part of the remedial strategies going forward. As far as the issue of case finding goes, so what I was saying was that those patients that have been diagnosed and started on treatment, right? They are stable. If they're not well, they come into the facility. But if they are stable, they are getting their medications, and so that is less of an issue. Of course, some patients do default, and we have to pick that up. But the bigger challenge, and like Ms. Shan has shown through the statistics, is we've been doing opportunistic screening of people coming into our health facilities, right? And of that, she kind of showed the figures there. You will see a very large number were screened, and of that, sputums sent off, diagnosis made, and then people started on treatment. Now, the fact that we've got a significant number of patients that has reduced, that the number of patients coming to our facility is significantly reduced, okay? That opportunity for screening has reduced. And so our ability to pick up cases of people coming to our health facilities has reduced. And that's what I was saying from a public health point of view. In terms of the those percentages that we start on treatment, there's always a drop-off in a sense that these sputum results are never it's not on the same day. So people come with symptoms, the sputum is sent off to the laboratory. By the time you get the results, the patient has to come back, etc. And in all of those steps, there's a kind of drop-off in terms of patients being picked up and started on treatment. You also have other bigger factors. For example, people migrate or move on, etc. Sometimes poor contact details, so the patient can't be tracked. So for a variety of reasons, we have lost to follow-up. And that's initial follow-up. That means somebody who's been diagnosed but not started on treatment, or somebody who's on established treatment but defaults on treatment. So loss to follow-up is a big concern in the department. We've recognized that. And again, strategies to remedy that is a big part of the department's work going forward. I think the issue of seasonal flu and co-infections, that is always a concern in this winter period, because oftentimes the symptoms are overlapping. So is this normal flu? Is this COVID? Is this TB? And that's where I think clinical judgment is going to be quite important. There's been serious challenges with COVID testing. So our ability to do tests and get results quickly has been seriously challenged in the country at large, but in this province specifically. And that makes it even all the more harder. But at the moment, it's largely a clinical call that is made by the primary healthcare nurse or by the doctor at the coalface. In terms of remedial actions, as far as this goes, like I was saying, I think awareness, education, using our community health workers to maximize the opportunity in each household visit to pick up on all of these issues, adherence to treatment, importance for coming back or follow-up, etc. So let me stop there and ask Mr. Krueger if he wants to add, and then Leslie Shen. James?
Thanks, Mrs. Chair, and thanks, Chris. So I want to ask, so obviously for active case finding, to simplify it, that obviously household contacts of people who have TB becomes important, and we have a good idea of who those household contacts are. and that obviously systemically those people should be screened. And then for us, a big concern is people with comorbidities, and that's people with mostly hypertension, diabetes, asthma, and HIV, that those people should obviously be screened for TB and put on treatment as well. We sent out a circular to services, and we've also extended it to our NPO partners, and they become a very important facet because many of our NPO partners have agency in communities, and so we've used a lot of, as Krisha, I'm just adding to what Krisha has explained, we're using some of our NPO partners as well to assist us with making the linkages to, because remember, we know exactly where our hotspots are for TB. So the idea would be, while we're doing COVID-19, we want to incorporate the TB screening. We are still grappling with if HIV testing could also be done in that space. And then just another thing that we've added to our circular is telephone follow-ups. So even if you lose cases in health facilities, doesn't deter clinicians to call a client, and those are the known clients. So at least we're keeping the known clients in care. Irrespective of COVID, we, in any case, if you look at Leslie's presentation, 9% of TB clients are lost to follow-up anyway. So if you look at literature, you'll see on average 9% of TB clients are lost to follow-up. So those 9% are very important. And that 9% present, I think, about 5,000 clients in our province. So it's not difficult to find them. So we think one of the ways of mopping up is using the current COVID modality to try and find these colleagues. Notwithstanding, it is difficult with migration, like Krisha said, notwithstanding that we do have people, the comorbidities with HIV, that there's about 30% of people that after 12 months, we struggle to keep them in treatment. Those, I mean, I want to be upfront to say those are some of our difficulties, even pre-COVID. But I think the system we've put in place where clinicians contact the ones who are currently in care, we've given them supply of treatment and they can make that connection, and that we want to use NPOs, funded and unfunded, to assist us with finding some of those missing cases and diverting them back into care. And some of that care and treatment we've identified, it doesn't always have to be done within a clinical facility. We have many NGOs that can assist and provide that. Chris has answered on the shelters as well. Obviously, in terms of the shelters, we would look at what are the risks for setting up, and unfortunately, COVID assists with physical distancing, because as you know, physical distancing is as important for TB as it is for COVID. So that kind of assists in TB safety, for lack of a better word. I don't know if that covers. And sorry, the last one on immunization. There's obviously scheduled immunization, and that's where the telephone calls comes in again, where we can call families and mothers in particular around the scheduling of immunization. Unfortunately, we can't do campaigns because of COVID and the lockdown, but we're hoping to do mop-ups with the cessation of COVID when we have more control over it and we've reached our peak. We should pick up with immunization campaigns the latter part of the year or early next year.
Thanks, James. Leslie, do you want to add?
Nothing much, Chris. Just to say that it is challenging contacting people, even patients, even though we've implemented that. Telephone numbers and cell phone numbers change. People, take out new contracts or so on. So our contact details for patients cause problems in keeping track of them as well.
Thanks, Leslie. And Madam Chair, I think the point that Mr. Krueger raised about loss to follow-up, why we regard those particular patients an important risk is, as you know, when they default on treatment, they become more prone to develop multi-drug resistant TB later on, which then becomes more difficult to diagnose, more difficult to manage, poorer prognosis, etc. So for all those reasons, defaulting on TB treatment is quite an important issue to try and reduce to absolute minimum. Thanks, Madam Chair.
Thank you very much, Dr. Vallabhji, Ms. Shant and Mr. Krueger. Members, are there any follow-up questions from your side at this stage?
Chairperson, mine is not a follow-up. I'm not sure. Must I post it now or must I wait up until the follow-ups are done?
Good morning, Member Windvogel. I'm glad that you also joined us. Would you like to pose a question to the department?
Thank you, Chair. Maybe, good morning, Chair. Let me first greet you. Thank you, Chair. Mine is, I think, the type of clarity. Maybe I missed it because I missed a part of the presentation and I didn't pick that up. The distribution of TB medication. I know that dot workers is very much involved. They normally take the medication home and patients will come and collect, and some of the patients come to the clinic and take the medication there. So now I'm thinking that was before COVID-19. Now my question is it still the same? Because my thinking is, if possible, to avoid the influx to the clinic, can't we also take the 30% who normally comes to the clinic and take the medication there, also giving it to the dot workers to assist those 30%? I just need clarity on that. Thank you, Chair.
Thank you, Member Windvogel. The department has extensively conveyed on the measures they use in order to reach the various communities, but I will just ask Mashant to just briefly respond to your questions for the purpose of you asking the question. If that's in order, please.
Thank you, Chair.
Thank you for the question. So we have implemented quite a few remedial actions to assist people outside of our facilities. That is the aim, is to try to reduce the number of people in our facilities. So we've got community health workers who are visiting people at their homes, delivering medication and also screening people. And we've also got pickup points outside of the facilities where patients can collect their medication. There've been a number of innovative medicine delivery mechanisms put in place. In the metro, just an example is the one that's been done together with Uber, and Uber then delivers the medication directly to the patient. Chris, I don't know if you want to add anything to that.
No, I think you've covered it. Thanks.
Are you happy, Member Windvogel? I think
Yes,
we can
Chair.
deal with anything other we can deal with during our recommendations or resolutions, should you have any follow-ups on that. Members, if there's no any more questions from your side, I wish to thank the department for presenting to us this morning. I think it was important for us to understand what the impact is to these services on in the current period that we are. I think we are happy that services are continued, even so more on a greater, more intensive basis within our communities, by where we know that we cannot allow overcrowding at facilities, or where people are now reluctant to visit these facilities for obvious reasons, that we have workers in the field that goes the extra mile to ensure that all services are covered within the health component. So I wish to thank you very much. We as a committee wish to extend our sincere thanks and appreciation for all the hard work that you do, for all the extra miles, and thank you for services rendered to our communities. I wish you a lovely day, and at this point, and a blessed week ahead. And I will now excuse you. We will deal within our committee. Members, please stay on the line with any additional recommendations or resolutions, which we will then forward to the department accordingly. So thank you very much for your time this morning.
Thanks, Madam Chair. Thank you very much.
Thank you, Madam Chair.
Thank
Goodbye.
you, Madam Chair.
Thank you. Goodbye.
Ms. Jamke, did you note any recommendations or resolutions, or should I go directly and ask for the members to submit those?
Ask them for the members. Ask the members to submit, Chair.
Sure. Members, the floor is open for you to pose your recommendation or your resolution.
Chair, Member Botha, none from my side.
Thank you, Member Botha. Member Barnes.
None from my side, Chair.
Thank you, Member Barnes. Member Allen.
I'm all good. Thank you so much.
Thank you very much. Member Van Vogel.
None from my side, Chairperson.
Thank you very much. Members, can we agree that should something come up in the meantime and there is something that you would like to address on the subject matter this morning, that we forward those before 2 o'clock today via email to our procedural officer? Is that fine?
Yes, Chairperson.
Yes,
Thank you,
Chairperson, and I also want to add to your proposal that should the procedural officer not receive anything, then we take it as concluded.
Absolutely. Thank you very much, Member Botha. Are all in concurrence, members?
Yes, Chairperson.
Thank you very much. And then we will deal at our next engagement with minutes. Is that correct, Ms. Jamke?
Yes, Chairperson is correct. The minutes of the 19th and the minutes of today.
Yes. Thank you very much, Ms. Jamke, for your support as well. Members, that brings our meeting to conclusion. Thank you so much for your time. Please keep safe out there, and I wish you a blessed week ahead. And this meeting is now adjourned. Thank you very much.
Thank you.